Thank you for joining today's Health, Education, and Learning Program webinar, ACOs, a tool to achieve quality savings and a return on your investment.
Well, today we're going to talk about the specific tools that help you achieve savings and achieve quality, achieve savings, and a return on your investment as you participate within an accountable care organization. And Kiona also mentioned the elements, the objectives for today's talk. And again, that's to describe how ACOs contribute to value-based care, name the key elements in ACO Success, explain the value in documenting risk, and finally identify the benefits of transitional care management and ED follow-up. So let's start with the basics. What is value-based care? Essentially, it's a sum of quality plus outcomes plus satisfaction divided by the cost. So the higher the quality, the greater the value, the higher the outcomes, the greater the value, the higher satisfaction, the greater the value. And again, by reducing the cost, it also increases it because you can provide all those that can be very expensive, but then it's not of value. Now, this actually translates to all three populations. For patients, this value will increase their trust in you and keep them coming back to you. For providers, it will increase their satisfaction and pride in their work. And for the payers, it'll reduce their costs and improve the health of their patient population. So what exactly is an ACO? Well, to some extent, the second bullet here is the same thing that you would see about a value-based care. It's coordinated care at the right time, the right place, avoiding things that are not necessary. But what sets ACOs apart is described in the first and third bullet. They're a group that come together to provide high quality and coordinated care. And by controlling those costs as a group, they're able to share in the benefits of reducing those costs and improving quality. So what are the elements of success in an ACO care saving program? Well, these are the four elements. Data. You need to know where your patients have been, where they've not been. You need to know if they follow up with a specialist or they've gotten the scans that you've ordered. You need to know if they're frequently in the emergency room. We're going to talk about tools that help you provide that value-based care. And the next two elements, both workflow and teamwork, are really going to be part of the second talk I'll give in about a month called ACOs, a team sport, because it really takes a team to be successful in this. So here are the tools for success. The first are the wellness visits, where you get your arms around your patient and truly understand them. Coding for risk, where you represent the disease burden of your patient population and of your individual patient. Chronic care management, where you provide support to those patients who are having challenges and help them stay as healthy as they can. Transitional care management, where you help those patients in that confusing time between discharge from the hospital to ambulatory care or to their home environment. ED follow-up to understand why they've been there and try and have them come to you first and make any changes that you need to do in order to help them come to you. And the last, which again we'll talk about next time, is team and provider buy-in. So let's start out with wellness visit. This is really the first thing that we find most effective in getting started within an ACO. You may already be doing this, and we just want to emphasize that it's a once yearly preventative focused visit that includes health risk assessment and a preventative care plan. This is holistic. It's not problem focused, but it's also an opportunity to document all of their medical diagnoses so that you truly understand what diseases or chronic diseases they're struggling with, what home environment things that they may be struggling with, and come up with a preventative care plan that is unique to them that helps address some of those needs. And that both you and the patient have that so that they know the plan going forward. So this is a part that can be confusing to some patients. You know, a patient comes in for a quote, a wellness visit, and they're expecting a physical exam. They're expecting a stethoscope on them. They want to look in your ears, check their reflexes, listen to their lungs, run lab tests, etc. That's not what a wellness visit is. It's not a complete physical. And it's also not an office visit that's designed to address a specific problem to support an E&M charge. Not what it is. What it truly is a once yearly preventative focused visit that includes a health risk assessment, as I mentioned, and a preventative care plan. The majority of this work is done by our other staff to gather this information together. You, as the provider, really only need to sign off on this plan. This is, again, an important opportunity to engage with patients and focus on their long-term health. You also get to understand, as I mentioned, some of their home environment and other needs that might not otherwise come up during an acute care visit. So let's look at some of the data we collected from primary care practices or independent practices who are not doing wellness visits that started doing wellness visits in this former ACO in which I worked. When they started doing wellness visits, they discovered that after they got them under their belt, there was a $30 per patient per month in reduced hospital costs and a $20 per patient per month reduced ED costs. And that's pretty significant because that's across the patient population. There was an overall 5.7% reduce in costs overall, and it was most pronounced in those patients that were in the highest risk factor. Also, since these providers may not be looking at these patients holistically, there was a much higher screening rate, and it was highest for those things such as falls risk and depression. So clearly doing these wellness visits really did make a difference in terms of cost and understanding their patients, and also enabling them to provide better care. So again, they focus on prevention. They increase the acuity of patients' disease burden, as I mentioned. They also increase attribution, which is important for an ACO, because in order to achieve shared savings, you have to get up to a minimum savings rate. And the more patients that are attributed to you, the lower the bar is for you to achieve shared savings. So you're more likely to be able to get it if you achieve, let's say, 3% savings or 2.5% savings with a larger population than you would if you had a smaller population. Also, your group begins to focus more on improvement, both in the patients and in the practice, and it aligns you all to population health. Also, for community health centers, there's a bonus, and an annual wellness visit will provide a 34% increase in fee. So doing wellness visits not only pays off for the patients and you, but it also pays off economically. Interesting story I have is one provider, again, this is a private practice provider who hadn't done any or wellness visits previously, and now started to do them fairly regularly. And his complaint was now he had to file more estimated tax because he was making more money than expected. What a bad problem to have, I say. So who should come in? All Medicare patients need to come in. And if in their first year of attaining Medicare B, so if it's within the 12-month period when they get eligible for Medicare B or they get Medicare B, you do a welcome to Medicare visit, which is one that is more thorough. There is an annual wellness visit that'll occur a year after that. There's a first one. And if they were ineligible for the welcome to Medicare, then they would get a first annual Medicare wellness visit. And then every year after that, they get a subsequent visit. Again, there is no specific billing type that's required for a wellness visit. But again, you do want to make sure that you represent all of those diseases, and we'll talk about risk in a moment, that add to the patient's disease burden. So what have some providers discovered when they've done these visits? They found that patients have seen multiple specialists, and you really don't understand the purpose. A couple of examples of that is patients that go to the cardiologist every 3 to 6 months just for a lipid panel and to renew their lipid medications. Something that you could do on your own, but the doctor was completely unaware of. So they found that out on the wellness visit and said, we can do this. If you need to see the cardiologist, we'll send you. Also, as a result of data, we discovered that there was a podiatrist who was seeing their patient pretty frequently and ordering a huge battery of tests, which really had nothing to do with the patient's foot needs. Well, we found that out in the data, confronted him, and he said, well, Medicare pays for it, so I was ordering it. And we got that public, and he changed his ways. You may sometimes have no records from these folks. They may be on medications that you're unaware, or they're unaware of the purpose, and you are as well, or they've been admitted to a hospital or no records of that admission. That happened during one wellness visit where there was no record of this patient having had a stroke. And the doctor found it out only at the end of the wellness visit. So there's several ways to complete them. The standalone visit is the ideal one, where they come in specifically for that. The time is set aside with the staff to be able to collect all the needed information and have a one-on-one discussion with the patient. These can be the most challenging to accomplish because when you call the patient and try and set one up, they said, well, I just saw the doc, why do I need to come in again? Or, hey, I feel fine, I don't feel the need to come in. So it may take some convincing on what this value of this wellness visit is. And that's really the responsibility of the staff who are calling and attempting to make that, or the provider who asks the patient who needs one to come in for a wellness visit after they're done seeing them. But it can be a challenge to convince them to come back in. The benefit for the patient, though, is it's free. Let's say they come in for a diabetes follow-up, and you actually have some more time, which is never true, but let's say you do. And you're a community health center. You can add on the wellness visit if your staff have time to collect the information, do the chronic visit, or the diabetes management, or the labs, et cetera, and bill for the annual wellness visit, which I said again is 34% more income, and not bill for the diabetes follow-up. There's nothing saying you can't put your stethoscope on a patient or order labs or see how they're doing for a chronic disease when you're doing an annual wellness visit. The billers sometimes get conflicted about it. They don't understand how that could be because it's a wellness visit, not a chronic disease management visit, but they'll come around because it really is better to do. It's good to bill for the annual wellness visit because number one, you get paid for it, and number two, you collect all that information. That way you capture patients that come in, but you also run the risk that you may miss some high-risk patients who don't come to your office. So you'd still want to reach out to those ones that are high risk. And finally, if you don't have time, you can either do one or the other. You can talk to the patient about flipping to an annual wellness visit, and they'll get a free visit. Now, if you haven't been doing wellness visits, it's pretty hard to convince patients to come in, and it also is more time-consuming for you in the beginning because there's a lot of information that you have to gather. But providers have found as time goes on, they become a more pleasant interaction. There's less information that they have to gather because they really know each other pretty well, and it really is just an update. So the more you do these wellness visits with the patients, the easier it is to do, and actually the more pleasant it is for both of you. So let's move on to the next one. This is representing risk. So what exactly is risk coding? Risk coding is the process of accurately and thoroughly communicating to Medicare the disease burden of your patient population and your specific patient. You do that through submitting the ICD-10 diagnostic codes. Risk adjustment is how the payers adjust the expected cost for patients based upon their risk weight. So how do you come up with risk weight? Well, here it is. There are some factors that you can't change. You can't change the patient's age or sex. Well, maybe you could, but you won't. And also, they'll be dual eligible or have disability. Those all are fixed items that go into the calculation of the risk burden. The other half is your responsibility. That's where you put in the diagnosis that you submit to Medicare or submit to any other payer. And each of those specific diagnoses can carry risk, and that risk is what raises the expected cost for those patients. So let me give an example. Let's say you don't do some very specific coding on your patient population, and the coding you have done says they should cost about $500,000 over the course of a year. But on the right-hand side, in reality, and this is not drawn to scale, obviously, but on the right-hand side, they really cost $1 million. So, hey, what's going on here? You're spending twice the amount of money that you should on them. So either you're running tests that are unnecessary or not taking good care of your patients, or your quality is off, something's wrong, and you not only don't get bragging rights, you may wind up paying back money to CMS if you're on a risk-based program. So you want to make sure that you code accurately. So for example, in the next slide, If you do code all those potential codes that are there, and the expected cost is $2 million for your patient population, and you only spend $1 million, woohoo, you're all of a sudden doing a great job. And based upon your great quality measures, you get a large portion of that shared with you from the payer, either be it CMS or whoever it is. So again, you want to make sure coding is specific and it is thorough. So I'm going to give you an example of a patient. This is a 76-year-old female, and she's Medicaid eligible, as you can see in the left column. Now, nothing else is coded, so she comes automatically with an expected per year cost at the very bottom of $6,450. Now, the average Medicare patient actually should cost about $10,000 by over our calculations. So in the second column, we've got some of the coding that's been done. The given ones of her age, Medicaid eligibility are there, but now we've coded for major depression. But there's a problem here. We use the one depression code that doesn't have any value, and that's major depression, single episode, unspecified. No way. Plain old diabetes, even though they have complications that is difficult to control, they're out of control all the time, but it's just coded as diabetes, has the weight. Vascular disease, simple vascular disease was coded without complications, which is also not true. No one, for some reason, coded CHF, and this patient is now an average patient of $10,000. I might add here that this coding doesn't depend just upon the primary care provider. It includes any codes that are done by specialists or the hospital over the course of a calendar year. Now, when I say calendar year, something magic happens on December 31st. The blind see, the lame take up their bed and walk, and all of a sudden, all of their codes go back to just the basics that we see in the left column. So we need to make sure that every year during the annual wellness visit or sometime during the year, we do represent all of their codes, all of their diseases, I should say, not their codes. So in the last column, we see much greater specificity. Again, we have the givens. Now we use major depression, and it could be single episode, mild, moderate, severe, recurrent major depression in remission. Any of those have weight. I also might add too here that these weights that are represented are from a couple of years ago. These weights change as everybody gets better at coding, because this is really a zero-sum game. And consequently, as people get better at coding, these weights go down a little bit. But this representation here is a good idea of why these are important. Now we code with complications. We see that as about 3 times the weight of no complications. We code vascular disease with those complications. Again, this is almost twice the amount, or 50% more really. Congestive heart failure is now coded. And in this particular instance, there's an interaction when the patient has both diabetes and congestive heart failure that has complications. And diabetes and congestive heart failure, regardless of whether they're complications. And there's an added bonus of about $1,000. So we now see that this patient expected cost is $23,680. So again, if you're providing this patient care at less than that cost, you begin to share in savings. So identifying their risk is also good in identifying those patients who are eligible or might be eligible for chronic care management. Let's go into that topic now. So what exactly is chronic care management? It is the care coordination that occurs outside regular office hours. It is expected that the disease that you're managing, 2 or more diseases, is expected to last at least a year or until the death of the patient, or if the patient is at significant risk of death, exacerbation, or decompensation. So in other words, they're at risk of death, then you can do chronic care management, and can also be delivered for patients with many different types of health conditions. So let's look at how this translates into costs. On the left-hand side, we see the number of conditions that a patient may have. So for those patients at the bottom with 1 or fewer conditions, they really only account for about 7% of Medicare spending. For the next 32% that have 2 or 3 conditions, they account for 19% of the spending, a significantly greater amount. For those with 4 or 5, we're now at 28%, and the top 14% account for almost half of the Medicare spending. So when it comes to care management, you really want to focus on those patients that have the highest disease burden, the highest risk score, and the ones that could benefit from it the most. I want to put a word of caution here. Many practices will outsource care management. And this business that does the care management will share some of the payments that they get for doing care management with you. So it frees your staff up for having to contact these patients and gives it to this organization. But where I want to caution you is their job is basically fee for service. They're not in there for quality of care. They want to do as much care management as they can. And they may work their way down that list. So they're actually working with patients with only 2 or 3 conditions, consequently running up the immediate costs, and in the long term, diminishing the amount or diminishing the chances that you'll get shared savings. So if you do use an organization that does the care management for you, you want to be sure that you know who they're calling, and you give them the names of those who are calling. But I also would like you to try and take it in-house, because again, we'll talk about it in a moment. When it's the practice that calls the patient and the practice that's checking in, that goes a long way to have those patients come back to you rather than just be managed by an outside organization. So there are a couple of different ways that this is done. There's the organizational model on the left-hand side, where it's a system-wide model that incorporates multiple modalities such as decision support, community resources, information systems, delivery system redesign, etc., to improve the care management of their patient population. The self-management, or the one that's more directed to the individual patient, is really focused on the patient's self-confidence and motivation to manage their own care and provide them with the tools they need for success. So we check in on them regularly, see how they're going, and capture any problems before they become more significant. And both of these processes have been demonstrated to be successful in reducing hospitalization utilization, improving health behaviors, and increasing patients' costs. So the requirements for care management: 2 or more chronic diseases that may last more than 12 months. The patient needs to sign a consent, either verbally or written. You need to provide them with a personal care plan. They have to have 24-hour access to a member of the care team for urgent needs. There is that enhanced face-to-face communication, which is you calling the patient and making sure they're okay. You manage their transitions from hospital to home or any particular pace, much like a care transition. And you spend at least 20 minutes. You can bill for it if you spend 20 minutes in a calendar month doing those sorts of services. And what types of services? Well, managing their chronic conditions, management of referrals to other providers, managing their prescriptions, and ongoing review of their status. Pretty much any of these things done by your staff go towards the 20-minute per month ability to bill for care management. I don't know if you can hear my dog snoring under the desk. So one thing that we did too is we talked to some of the care managers who've been doing it for a while to get their impression on how it worked. And they really liked it because it gave them the opportunity to establish a relationship with their patients, which was valuable. The patients were calling them and felt like they could depend upon them. They could use that time to find out what they were struggling with and find some solutions for them. They encouraged patients that were feeling discouraged and really give them feedback on how they're doing. And true feedback, because we know things don't change overnight. They know that patients had more of a sense of security, that they were there to be reached if they needed to. And they felt, and as the data that I showed you earlier, it decreased ED visits. It was promoting wellness for those patients, and the patients were really feeling like the center of the care. So again, chronic care management is a tool at your disposal that can help you keep track of your patients, help them feel more connected to your practice, intervene before the problems start, and make sure that they're clear on the plan going forward to help keep them healthy. So the next topic, or the next tool, is transitional care management. And this is essentially when patients are transferred, occurs when patients are transferred from an inpatient facility to their home. So there are a lot of things that actually count as inpatient. Obviously, an acute care stay, but it also includes a long-term acute care hospital, a skilled nursing facility, an inpatient rehab facility, or if they're in for hospital observation or partial hospitalization. Any of those count as the opportunity to do a transitional care management visit. And these are patients that are going home, to a nursing home, to assisted living, or any other place that they pretty much call, pretty much has been their home. So what are the components? First is that you contact the beneficiary or their caregiver within 2 business days after discharge. And the day of discharge is called day 1. So if they're discharged late on Friday, you may have to make sure you call them by the end of the business day on Monday. Or if it's a holiday, I think it can go to Tuesday. You do a follow-up visit if they're severe, or if it's a really complicated patient, within 7, or if not so complicated, 14 days. Perform medication reconciliation, which is really the most important component, because so many times patients get confused about the medications that they were on, that they should stop, what they need to start. Sometimes they'll appear in brand names, sometimes they'll appear in generic. I mean, this is your opportunity to really help them understand what their medication, what they should be taking and how they should be taking it. You obviously want to obtain the discharge information and review that, any of the diagnostic tests and treatments, and follow up any that are still pending. It's a good opportunity too to educate the patient or their family members or caregivers on the hospitalization and what is expected and what follow-up is expected. You manage any referrals during that time visit and schedule any follow-up with other providers or the other services. So what have some ACOs found that have done transitional care visits? So this is data by Inspira Health, which is an integrated care system on an ACO in New Jersey. And they had 3 groups of 1,000 patients that they looked at. The first patients were the ones that received a transitional care visit. And those patients, they discovered that their readmission rate was about 11.65%. Now, a year or more ago, the 90th percentile for readmissions were if you were below 14%, you got all your points for readmissions. So the patients that had a TCM, if you get them all to do a TCM, it was obviously you're doing a great job on reducing readmissions, and you get a great score on getting all the shared savings you would expect to get because of your quality measure. For those patients that were seen by their primary care provider, but it wasn't a formal transitional care, those rehospitalizations increased by about 50%, which was statistically significant. And for those who had no visit whatsoever, they had almost twice the readmission rate, both of which, both the PCP visit that wasn't a TCM and those that had no visit, were above the expected rate for readmissions to the hospital. So there are a couple of things here. Again, hospital readmissions cost the system money. Readmissions within 30 days cost the hospital because they have to reimburse for that care unless it's something completely different. And it also means patients are in the hospital and not at home, because we're not only looking at the dollar value of this, but we want people at home and in their own beds with their families and not sitting in a hospital bed. Another study that we did in a primary care ACO, we discovered that for every 12 transitional care visits done, it eliminated, amongst high-risk patients, it eliminated 1 readmission. I'm hearing a little feedback. But in those low to moderate risk patients, it took 23 visits to eliminate 1 readmission. So again, focusing on those patients who are at highest risk really is provides you with the greatest benefit and provides your patients with the greatest benefit. So to review the timeline, day 1 is the day of the patient discharge. You need to have an interactive contact with the patient by the end of day 2. Now, there is a caveat here, or there is an out here. Let's say you try 2 times to contact the patient and there's no answer, but they follow up with you within either 7 or 14 days. You can still bill that as a transitional care visit because you attempted to make the call, were unable to have that call go through, but still were able to see them. So even if you're unable to reach them after 2 attempts, you're still able to do a TCM visit. And that TCM time period is for 30 days. So if they're admitted again within that 30 days, you can only count for 1 TCM and the other one will have to be a regular E&M office visit. Something else that just slipped my mind. Oh, yes, now I have it. Despite the fact here in this previous slide, I talked about the PCP visits had 50% more readmissions than the TCM. It's not the magic of billing a TCM. The magic is what you do with the patient when you see them. It's checking their medications, making sure they understand them, setting up the follow-up plan, and really put your arms around them after the discharge. If you see them for a follow-up visit and maybe collect some information, but don't really do all that a transitional care visit can provide for the patient, that's where things can fall through the cracks. So again, whether or not you bill TCM, if they come in with those 14 days or 30 days, you want to make sure that they understand everything that they need as a result of that hospitalization. So the next topic and the last tool in the toolkit that I'll talk about today are ED follow-up. Now, this is from an old study in 2007, so obviously the dollar amount now is probably almost twice that. But this study that was done then found that about $38 billion of unnecessary care in emergency departments during 2007, or actually during 2007, unnecessary care in the emergency department amounted to $38 billion. And some of this was as a result of lack of access to primary care. And they found in their study that all the ED visits, 13.7 or 21% could have been managed at a retail clinic or at an urgent care clinic. I do want to insert a caveat here though too. Obviously urgent care is better than an ED, but the urgent care doesn't know your patients as well as you do. So you really want them to come to you because an urgent care clinic may panic and send to the emergency room. That was my son-in-law had that experience where the emergency room saw him, thought he was going to bleed to death, even though he had been fined for 5 hours that day, and they sent him to the emergency room. Oh well, the emergency room said he really didn't need to be there, and he thought so as well. In West Virginia, they actually set up an agreement between a chain of urgent care clinics to contact them, or if they felt it was something that could wait till the next day, rather than run a bunch of tests in the urgent care clinic, they set up an appointment for the patients with the providers the next day so they could be seen in the clinic. Now that was an interesting way to prevent hospitalizations and to prevent some unnecessary costs and keep them coming back to their primary providers. So again, we see the reduction in ED recurrence. For every 12 successful follow-ups, we avoid 1 ED visit within 30 days. For every 13, we prevent 1 in 90 days. And the savings per practice per completed call was roughly about $85. So again, it's significant since that really only takes about 10 minutes to do that call. And that's something your staff can do. There's some very specific questions you can ask, which I'll talk about in a moment, but here are some of the top reasons we found in some of our practices when we analyzed the data with patients that went to the emergency room and were not admitted to the hospital. The top reason really was urinary tract infection. Next came chest pain, hypertension, low back pain, and everybody's favorite diagnosis, dizziness and giddiness. So many of these conditions can easily be treated by the primary care provider. And the benefits include understanding when you call them, understanding why they went. Did you try calling us? You can develop a personalized protocol for the patient. And it also can increase the chances they'll reach out to you first, as opposed to going to the emergency room. So what do you do in preparation for the call? Well, you want to look at the data you have and see how many ED and inpatient visits they've had in the past 6 months. So you know if this is unusual for them or if this appears to be their usual pattern. Are they already on the schedule to be seen after they were at the emergency room? So that's good to know. It's also good to know if they were seen prior to, if it occurred during office hours. So why didn't they come in? And were they on the schedule shortly before? And was it something that was missed or came up suddenly or wasn't addressed to their satisfaction? So when speaking with a patient, you really want to understand if it was sudden or if it was chronic. Ask why they didn't try reaching out to us, or if they did, what happened. You want to see if they're feeling better, or they went to the emergency room and they really don't feel any better. And ask them, well, would you like to talk to one of our providers now? Maybe they could help you out, and make them aware that you do have, you're able to schedule same day appointments. So things that you may learn, that they were not aware that there were appointments. They felt that the phone tree options were confusing. And it starts out with, if you think this is emergency, please call 911. Well, the patient may actually think this is emergency and then hang up and call 911, even though they tried to call you. They may be calling because they have no transportation, and having an ambulance send them to the emergency room is the easiest way for them to be seen. And they went to an urgent care first, as my son-in-law did, and was sent to the emergency department. So this will actually identify some examples. Well, this is actually some examples of feedback they received when they did this follow-up call. Patients had no idea they were open after hours. No one had actually called them back. The soonest appointment was weeks away. And they were sent from the front desk to voicemail, and they panicked because they really wanted more immediate feedback. Changes that you can make is optimizing your phone tree, so that, and maybe even have one of your staff or you try and navigate your phone tree and see what happens. You want to be able to standardize that greeting and define standards for turnaround. So who owns these voicemails? What is the expected turnaround, and what is the patient's expectation of a turnaround when they call in? Helps to develop a protocol for scheduling appointments, so 2 weeks out is not appropriate, and educate patients about after-hours calls. So these calls will help identify barriers to care, address any access to care issues in your practice, schedule needed follow-up appointments, determine the necessity of new specialist referrals, who needed additional care management, highlight your same-day appointments, help your patients navigate the healthcare system, lead those patients into care management who actually need it, and decrease cost. And from the patient perspective, it'll improve their satisfaction, it'll engage them more in their care, and also building a trusting relationship between you and your patients. Now, there are two other elements that I left out. One was around chronic disease management. And there's an example of a patient in West Virginia, a patient that practiced in West Virginia. This is a patient that had asthma, had COPD, and anxiety. And this patient's pattern was to go to the emergency room every Friday night or Saturday because they were afraid that they were going to be sick and weren't going to make it through the weekend until the practice was open again on Monday. So what the doctor decided to do is have the care manager call this patient every Friday afternoon, check in with them, see how they're doing, ask them if they want to be seen, and make sure that they were comfortable. They also set up a protocol with the emergency department where They could provide medications for the patients if he really was not doing well and send him home, because this really was more of a pattern than it was anything that really required an emergency department visit or hospitalization. And that wound up to be very successful and wound up keeping that patient from going to the emergency room and significantly reduced it. The other thing that I neglected to mention is that emergency department visits can also be a good funnel for care management. So again, for those patients who are seen very frequently in the emergency room or who are at high risk, you can make sure that you get them engaged in care management, just like this West Virginia patient that I mentioned. And that contact with the practice and understanding that the practice is there for them can help reduce their utilization of the emergency department. So for that, the reach outs to EDs, follow-ups, the reach out for transitional care really pays off in long-term benefits. So finally, to review. Today, we talked about 5 tools that are very effective in terms of getting shared savings and improving quality for your patients as part of an ACO. The first of those, annual wellness visits, where you understand your patient's needs, both medical needs, social needs, et cetera, and create a care plan for them. The next is documenting risk, where you accurately represent the disease burdens. You're able to identify patients who are at highest risk and funnel them into care management as needed. And also I allow the payers to understand that this is not a population, or this is a population that is complex and is going to require complex care. So they will understand that the costs are going to be higher for your patient population. And for that respect too, it will be higher for your community as well. So for some of the community health centers, they use that as a demonstration of the fact that our community does require greater support. Chronic care management, which allows you to help hold the hands of those patients that are struggling managing their illness. Transitional care, which makes sure patients have a healthy have a good transition from hospital to home, so that their medications are understood, the follow-up can is understood, and nothing falls through the cracks. And the ED follow-up, which allows you to understand why they're going to the ED. Is there some barrier they're coming in? Did they not know that you're open? And did they not know that there's a way for you to see them if needed? So this really is, everyone on the team really needs to understand the value of all of these things. They need to understand the value of prevention, understand the focus on quality, and the focus on cost and utilization. And finally, they need to understand that capture of risk through accurate coding. Everybody on the team can take part in this. Many of them will have this question, okay, I believe in that, now how can I do that? Now, this really will create a whole new way of doing things that is a team effort. And we're going to talk about the way that we can implement this the next time, how we can implement this into a practice in a way that fits for your practice, and we can get the entire team engaged so that it really becomes a successful process. So with that, I'll end here. Thank you very much for your attention. One thing I want to reassure folks, I don't know, oh, good, we have a question coming in maybe. One thing I do want to reassure folks is that this is an ongoing process. I was also involved in the implementation of many EHRs over time, and EHR vendors typically give you a crash course on how to use it and then disappear. That's not what we do when we introduce you to this whole new process of ACO. It's not something that magically happens. It's not something that happens overnight. It is a process that requires a team, and it's an iterative process, because you're not going to get it perfect the first time, just like you don't get using an EHR perfect the first time. So again, we will want to provide you with the tools that you need for process redesign, so you're able to actually implement these things within your practice. And we're not going to leave you out there hanging, trying to figure out what in the heck do I do now that I'm trying to get this accomplished.
In March, Dr. Kleberg is going to join us again to dive deeper into ACO implementation and specifically how the describing the elements to help build a team to successfully manage the transition. So if you would like to participate and view that live recording, please register on our website for that. We also have another question. They're curious if, in your experience, if commercial payers have provided the raw data to validate the outcomes.
So other payers will provide raw data. So for example, they will provide information, but we have found that there's a delay in getting that information. So a buddy of mine says it's kind of like adjusting the temperature of your shower. You turn the key, but it's only a while later that you found out if you did it right or not. So are you scalded or are you freezing? So they will provide that kind of data, but it is slow in coming, and sometimes they're able. Some ACOs have been able to negotiate getting that data earlier with some of those payers. But yes, I agree. It can be very hard to come by. That is a very good question. And it's something that is a benefit to the payers to do, because again, if we have that information at the point of care, as opposed to saying 3 months later, you didn't do something, I mean, that's pointless. You want to know when the patient walks into your office, what do they need? Do they need a colonoscopy? Did they follow up for that mammogram? You need that information then and now, not 3 months later. And in reality, CMS is not a whole lot better than that. But depending upon the EHR system, or if you're using eye-to-eye or something else like that, you may actually have that information pulled out of your own chart.
We have an additional question asking, how do you analyze data for multiple discharge diagnosis?
How do you analyze data? I'm not exactly sure what's asked. How do you analyze data for multiple discharge diagnosis? So usually there's a primary diagnosis on discharge. And what we had done in the example that I gave, we actually had a listing of the patients. We had their the primary diagnoses and all the secondary diagnoses for their hospital admission. And for example, in the emergency department, they had the same thing, and we're able to filter out whether or not they were actually admitted to the hospital. So that's how we got the list of patients that were seen, their diagnosis, and they were not admitted. The way you analyze them is if you have got data from all your patients and put them into in a spreadsheet, and do a sort of a tilt table. Not tilt table, pivot table to try and identify the highest numbers, etc. So it requires some juggling and some technical skills to be able to do that, because the data that comes to your raw really is, in some respects, gobbledygook, but there is good information within there. Yes, well, depending, you mentioned for your reports, it depends. I have not, to be honest, I've not seen the reports that are available to you, but if I were able to see those reports, I'd be able to answer that more clearly. Your data analyst would be able to help you with that. Again, I'd like to, I think it's important for an ACO. An ACO is kind of like a union. In a sense, you've got more power now that you're a group. And if you tell, the payers want to win as well as you do. And if you can convince them that it's in their best interest to provide you this data in a timely fashion, because data at the point of care increases the probability that you're able to do what's needed, then they're more likely to be able to give it to you. Data really is king. And having that data and being able to understand that data really is key. Thank you all. And I do want to emphasize that this is not just about shared savings, but this is about providing high value and better care for your patients, so they're able to keep them at home and help them to live valuable and productive lives. So thank you all for joining, and best of luck.
Thank you.